my name is Liz. I am the Director of Field Education, so my primary role at St. Mary's is placing students in internships for the St. Mary's LCSW program. So if anybody's interested, let me know afterwards and we can talk. We are an online program though, so we have students placed all over the country. We currently have students in Illinois, Indiana, Michigan, and Texas. So we're growing, hopefully more. Welcome to everybody online too. If you have questions, you can throw them in the chat, and we have people who are looking at that and can share them. As Lisa said, I've been in social work now for 19 years, 17 years in the field. I did court advocacy work with the CASA program here in town, community mental health, both as a caseworker, then as a therapist after I got my master's degree. I did some school social work for a year in a high needs high poverty school here in town. And I still work at a private practice here in Osceola. When Lisa reached out, I tried to get my colleagues to do this presentation. I'm not much of a public speaker, so I always try to find someone else who's more comfortable doing it. They didn't feel that they were ethical enough, is what they told me. But here we are. So I started this presentation in January. I was actually reading a book at the time called Compassionomics. It's geared more towards healthcare workers, but it also works in mental health as well. And so I think that's probably where compassion and ethics came in at the time. And then in February, the NASW sent out their March Social Work Awareness theme, which is compassion and action. So it's like, well, it was meant to be. So here we are with compassion and ethics. So my first question, turn that off. My first question, if you want to take your phones out and you scan the QR code, it should bring up some things for you to answer. In 1 or 2 words, why did you get into social work or mental health? What brought you here? Well, the fun part is at the end it saves this. It'll save this for us so we can keep it, which is fun. So feel free to keep adding to this. But the biggest part we can see actually in the middle is compassion, helping, advocacy. One of them was my younger self needed me. I think a lot of us come in to social work and mental health for all of these reasons. I didn't come into social work in a traditional way. I didn't go for a bachelor's in social work. I was an education major. I taught for 5 years. And I decided that while I liked kids, I didn't like 30 of them at a time. So I knew I needed to do something else. I didn't know what that something else was. At the time, my father-in-law was a juvenile court magistrate. He said, well, you should try this. And this was the CASA program. And that was my jump into social work. And so I've talked to him several times, but I'm always grateful that he was the one that pushed me towards social work. Because I still get to work with kids if I want to, but I also can do so many other things. A couple more questions for you. What's your job title? So many times I've found in mental health and social work, Our job titles don't accurately reflect our backgrounds, our expertise, and our education. And I'm not sure about our mental health friends, but I know in social work, a lot of people don't use the term social worker because it has negative connotations. We have quite the array of different titles, even though we all have similar backgrounds and educations. One last question before we keep going. How long have you been in the social work or mental health profession?
Well,
That's so much experience. When you think about the people that are sitting here physically in the room, our friends online, and we look at all of that, how many years we have helping other people in our community. That's amazing. Amazing amount of knowledge and compassion and advocacy skills. We'll get on to some of the more boring parts, but I promise there'll be more interactive ones coming. Our goals today are to explain how compassion and ethics are similar, how they go together, to interpret the NASW and the AMHCA ethical principles in different situations or scenarios. I'm a social worker, so my lens is always social work. I tried really hard to learn those AMHCA principles. To be able to defend your decision in different ethical dilemmas utilizing those principles and other evidence-based research. To identify that we all have personal biases, we all have our own set of personal ethical standards, and compare how those align with the NASW and the AMHCA principles. To recognize the importance of compassion in our decision-making skills. And then at the end, we have some case scenarios that we can identify possible ethical dilemmas and how we would handle them. So any ethics training comes with a deep dive down into ethical principles. The NASW has 6 of them. The AMHCA has 7 broad principles that we follow. We're going to briefly go through these as a reminder. And as we work throughout the morning, use the ones that most align with your role. We'll start with NASW, then go to AMHCA. And I think what you'll notice is there's a lot of overlap. The first NASW principle is service. So social workers elevate service to others above self-interest. Social workers draw on their knowledge, their skills, their values to help people in need and to address social problems. Social workers are encouraged to volunteer some portion of their professional skills with no expectation of significant financial return. And I'm sure if you're interested in doing that, Lisa would be happy to talk to you at the end.
you have somebody speaking at 11:50 on that variation, so we got you covered.
The second NASW principle is social justice. Social workers pursue social change, particularly with and on behalf of vulnerable and oppressed individuals and groups of people. Social workers' social change efforts are focused primarily on issues of poverty, unemployment, discrimination, and other forms of social justice. These activities seek to promote sensitivity to and knowledge about oppression and cultural and ethnic diversity. Social workers strive to ensure access to needed information, services, and resources, equality of opportunity, and meaningful participation in decision-making for all people. And as we know, some of that is falling by the wayside at this point. But luckily enough for social workers, we have a governing body that says, this is what we need to do, despite what others are saying. The third principle for social workers is dignity and worth of the person. So social workers treat each person in a caring and respectful fashion, mindful of individual differences and cultural and ethnic diversity. Social workers promote clients' socially responsible and self-determination skills. Social workers seek to enhance clients' capacity and opportunity to change and to address their own needs. They seek to resolve conflict between clients' interests and the broader society's interests in a socially responsible manner, consistent with the values, ethical principles, and ethical standards of the profession. Social workers understand that relationships between and among people are an important vehicle for change. If we don't have good relationships, we can't make change. Doesn't matter what your skills are, you can't do those relationships. So social workers engage people as partners in the helping process. They seek to strengthen relationships among people in a purposeful effort to promote, restore, maintain, and enhance the well-being of individuals, families, groups, organizations, and communities. Social workers are continually aware of the profession's mission, values, ethical principles, and standards, and practice in a manner that's consistent with them. They should take measures to care for themselves and both professionally and personally. Social workers act honestly and responsibly and promote ethical practices on the part of the organizations with which they're affiliated. And then the last social work ethical principle is competence. So social workers continually strive to increase their professional knowledge and skills and apply them in practice. Social workers should aspire to contribute to the knowledge base of the profession, which is why you're all here. And then our AMHC friends. So theirs are written as commitments, which I liked, because we all have a commitment to the people that we're servicing. So the first AMHC principle was a commitment to clients. The commitment to clients covered many areas: the counselor-client relationship, the counseling process, the counselor's responsibility for integrity and assessment and diagnosis, record keeping, fees and bartering, and taking a consultant or advocacy role. CMHCs have a commitment to other professionals, and this includes the relationship between practitioners and colleagues, as well as practitioners and other professionals, and in clinical consultations. A commitment to students, to supervisees, and employee relationships. I particularly liked this one as a person who places students. We don't talk about that very much with the NASW principles. And so it was nice to see that that's a commitment for AMHC friends. The commitment also covered clinical supervision and making sure that things were held in confidence. Our CMHC friends have a commitment to the profession as well, which also discussed teaching, research and publishing, and a service on public and private boards, and service within the other organizations and communities. And a commitment to the public, which also also included how practitioners market themselves and any public statements that they would make regarding mental health. And then lastly, they're committed to resolving ethical problems between each other and between their clients and others. And I learned that our CMHC friends have an ethics committee that they can go to if they can't handle an ethical problem on their own. So, that was news. Now that we've gotten through all the principles, a lot of them, let's talk about the definitions we're going to use today as we talk about how compassion fits with ethics. And when we talk about compassion, I think it's also important to define empathy and sympathy. So compassion is the emotional response to another person's pain or suffering that involves an authentic desire to help, which is different when we think about empathy, which is the ability to understand and share feelings of another person, and sympathy, which is the feeling of sorrow or understanding someone else's misfortune. They're all very intertwined, but they're all very different. Any questions so far? Thoughts? So I'm a visual person. I like pictures to explain concepts. So here we can see in this picture, the sympathy part means it often looks like we're looking on. We say phrases like, I'm so sorry that happened to you, or my thoughts and prayers are with you. And those are nice, but if you've been on the receiving end of them, it's often not very helpful. I think in the world we live in now with social media, it often feels very empty. When we look at empathy, he's the person that's sitting in the water. Empathy is sitting alongside of a person while they're struggling, while they're in that hole. And that's where we hear phrases like, I'm so sorry that happened to you. I'm here for you. What can I do? I'll keep praying for you. They have a little more meaning behind them, but still not to where that help is coming. And then we have a compassion person, and he's there trying to pull the person out of the hole. Because compassion is action. I'm so sorry that happened to you. I brought you a meal for next week. I'm coming on Saturday to help you clean up the house or run your errands so you don't have to. That compassion piece is where we pull in the action.
Sympathy, empathy, compassion. These three words.
So how many of you have ever seen the Brene Brown short video that's sympathy and empathy? Right? It's been around for a long time. It's one of my favorite videos to share with students because they don't often understand the difference. And in that video, there's a bear, a fox, and a goat character. And the fox is going through something, and the bear climbs down a ladder into the hole and stands with the fox and is helping her through this issue. My favorite part of that video, which is probably the worst part of that video, is the goat comes along, looks down in the hole and says, hey, I want a sandwich. Because the goat was trying to help, but it wasn't really helpful, right? So I wish she would have gone further in that and added compassion in, because compassion would have looked like someone helping that fox climb back up out of the ladder, out of the hole. And so I found a different video that talked about compassion, empathy, and sympathy. So we'll watch that and kind of talk about it. Move it out.
Often get used synonymously, but there are some important differences. When you think of compassion in particular, what comes to mind? How is it different or similar to sympathy and empathy? It can be tricky to tell between them to begin with, but knowing what compassion really is crucial when researching these topics. Here at the Compassion Research Lab, we've conducted extensive research on compassion. We've looked long and hard at what it is and how it differs from sympathy and empathy. We did this by reviewing the scientific literature and by speaking with patients directly about their experiences. Both the literature we reviewed and the patients we spoke to gave us a comprehensive understanding of the true nature of compassion. To illustrate, let's imagine you're a patient recently diagnosed with cancer. Your outlook is good, but you're worried. On top of all of this, it's happened right in the middle of a big move. Hearing about this, you notice your family, friends, co-workers, and healthcare providers all react in different ways. Oh my goodness, that sounds awful. Are you going to be okay? I'm so sorry. It must be horrible. Thinking of you, this is sympathy. It's a pity-based response based on a lack of understanding. It makes people say things that make them feel better, but it doesn't do much for you. Then there are others that try to understand what it would be like for them if they were in your situation by trying to feel what you are feeling. They tell you that they know what you're going through. They imagine what it would be like for them to be in your shoes. They might tell you that they have gone through something similar. This is empathy. It makes you feel heard, understood, and a bit better about your situation. But then there are those who try to really understand what it is like for you, to feel what you feel, and who aren't afraid to suffer with you and to do something to help. They actively listen, they're kind, they're loving, and they genuinely seek to understand you and your unique needs. But then they go one step further and show up on the weekend to help out with the big move. They haven't said they feel sorry for you. They haven't just understood you. They have been selfless and done something to help. They aren't afraid to engage you in your suffering. They understand you and what you actually need, not just what they would want if they were in your shoes. Most important of all, they actually do something to improve your situation. That is compassion. Sympathy, empathy, and compassion may seem similar, but for those experiencing suffering, the differences are obvious and impactful. Patients told us that sympathy was unwelcome and unhelpful. They told us that empathy was better because it attempted to understand what it would be like to be in another person's shoes. But compassion took things to the next level by understanding and addressing a patient's needs in a personalized manner, not just through words or feelings, but by putting their ego aside and by getting their hands dirty in order to actively engage and alleviate a person's suffering.
So all of that to say, compassion is active. It's fully sympathy and empathy all into one thing and using that to be an active participant in someone else's suffering. So much like everything else in the world, compassion is also on a continuum. Where is the emotion, action, or thing completely black and white? I know it's small, hopefully you can see it. But on the low compassion end of the spectrum, we see people who appear to be uncaring, are often critical of themselves or other people. They engage in othering and focus mostly on self-interest. On the opposite end of the continuum, we see people who often care about others out of a sense of guilt. They become martyrs. They indulge in activities in the name of compassion, but not necessarily because they really want to do it. Sometimes they're overconfident which gets in their way of actually helping. And then so like most things, kind of finding the middle ground is where we want to strive for. So people who find the middle ground of being a compassionate person tend to build trust and psychological safety for others. They unconditionally accept both themselves and others physically and mentally. They understand and accept strengths and limitations. We're going to talk about that in a little bit too. They bridge divisiveness so they can see both sides, often of an argument, and help come together in the middle. And they think about the benefit of everyone that's involved. Because rarely is something singular. So many problems involve multiple people and they grow. So another question for you. How compassionate did you feel when you started in the mental health field? Some of us have to think back a lot of years. Most of us felt pretty compassionate when we started. Some of us probably had that mindset that we were going to save the world. We were going to do all of the things. Right? How compassionate do you feel today? When you have to think about getting up to go to work, the client load that you have, writing your notes, getting everything ready for the day, is it the same? So I'm really happy to see a lot of you still feel fairly compassionate, but it is not the same, right, as when we first started. I think that's normal. So, as Lisa said, I love neuroscience stuff too. It's definitely not a field I've spent a lot of time in, but just like a little bit, just enough to know enough to be dangerous with it. I also live with a hard science person. He does chemistry and biology for a living. And so when I talk about mental health, it doesn't make sense. He doesn't get it because there's not hard rules. There's not a formula for him to follow to fix a problem, right? So when you put both of us together, if I want to talk about work, I have to figure out ways to make it make sense for him. So the neuroscience behind empathy, when we feel empathy for someone else, pain centers in our own brain light up. I think that's amazing. I can literally feel your pain. Now you'll notice it's not as much as the person who's actually experiencing that pain, but it's still there. It's so neat.
It is.
Right? And I know there's some other neuroscience people in here because I recognize it. But we don't know a lot about brain science, but like we know this. empathy can make us feel someone else's pain. So, really cool. When we feel compassion, that feeling of wanting to act, wanting to fix, wanting to help, it's not the pain center that lights up in our own brains. It's the reward pathways that light up. So I'm not going to say these right because, again, right, I know just enough to be dangerous in neuroscience. It's the nucleus accumbens, the ventral tegmental areas, and the hypothalamus that light up when we feel compassion. These are the regions in our brain that are responsible for dopamine release. What happens when we release dopamine?
Feel better.
We feel better, right? Right? So when we feel compassion for people, we feel better. I've ever had a really difficult session, and you didn't really know what to say, but at the end, your client says, "Thank you so much, that really helped."
Yeah.
How does that make you feel? Right? You feel better. And I've been there. I'm looking at them, they're looking at me, and I'm thinking, I don't even know what to do. But it worked, right? Makes us feel better. Now, how many of you have ever worked with a client that seemed to lack the ability to connect with others? Right? Were they also a person that struggled in being happy? Usually, right? How compassionate of a person were they? So I know in the private practice that I work at, there's a sign. There are all kinds of signs. And one of them talks about how to release dopamine. And I read it because it's down the hallway to my office. And so every time I walk by, one of the little things catches my eye. But then I read this and I was like, ooh, my work releases dopamine. And that's kind of cool. So that's great. But all of us only have so much to give. And you might be sitting there thinking, I'm burnt out. I can't keep doing this. This is hard work. How do you keep acting compassionately when you only have so much? If you gave money to every person that asked, or you said yes every time someone asked you for help, either physical or emotional, we would have given away our paychecks. We would never have time to handle our own responsibilities. And we'd be so burnt out we weren't effective. So what do we do when we can't give anymore? We recognize that compassion is action. We have to take care of ourselves. We make sure that we take care of our colleagues and our loved ones when they're struggling. So we need to make sure we do it for us. So how many of you talk to your clients about self-care and self-compassion? You probably know my next question. How many of you actually do it yourselves?
Not good at it, no.
No, none of us are. How many of you have ever disclosed that to a client?
I know.
I have too. And then they look at you and say, how can you tell me to do something when you don't do it? And then that reminds me that I probably need to do it too. Right? And I think we got off a few years ago on a really bad note with self-care and what that looks like. Because it was self-care was long bubble baths and drinking wine and going on trips and doing all those things, right? I don't know about you, but sometimes for me, self-care is taking a long drive and listening to terrible 90s hip-hop. Because then I can yell in the car. And sometimes that's all it takes. I do remember when I was first married, and I don't know if it was somebody that told me this or if I had read it somewhere, that a relationship was 50-50. And at the time, I was young and that made sense. There's two people, you split things equally, everybody has a part, right? And 50-50 added up to 100, it made sense. When you're in social work, I'm not a math person, 50-50, 100 was great. At some point, I realized that's not how it works. And it's not how it works, not just in a marriage, but in any relationship. Friendships, work relationships, right? Some days my 100% for that day is really like 20%. But my spouse might have to kick in that extra 80, and we make it work. Some days at St. Mary's, my 100% looks like 60. And I have amazing colleagues that will kick in the other 40 if we need it, right? That's compassion. That's recognizing that someone needs help and giving in. What does that look for like with clients? Do you always have 100% of yourself to give to a client? What do you do on those days?
I ask them a lot of questions. Demonstrate curiosity. I let them try to demonstrate self-compassion. I try to lead them in that direction. So basically do my job for me.
Yeah.
I pawn it off on them. And then I call it teaching.
Excellent. Other people, what else do you do when you have those days? When you're sick, but you know you have to go anyway. When your home life is falling apart, because it does, and you still have to go. What do you do? I think the worst advice I was ever given as a kid was leave it at the door.
Yeah.
It doesn't work, right?
I was going to say that I've been dealing with pain for the first time in my life. And there are times where I'm like, do I let the client know that I am struggling today with pain? But I want to be careful because it's not their problem to tend to. But the question does come to me of how much do we share if we're not 100% that day.
What do you do? What do you all share? I'm not an expert on it. I can tell you what I do, but I don't know if it's right or wrong. Right? Self-disclosure is a teetery-tottery fine line. Right?
There's a level of transparency that you can share without being divulged too much personal information. You can basically conversation kind of neutral, but still disclose that I'm not feeling my best today, but we're gonna make this work. And how can we make this work together?
Exactly. That's similar to what I do. I'm not feeling on top of my game today. I'm gonna do the best we can together. Right? I don't have to tell you why or what's happening. But I also think it humanizes, right? It puts us less in that position of power.
Yes, absolutely.
When we say, I'm struggling too. Because how many of you, and I don't know if you've ever had this, they think because you're a social worker or you're a mental health person that you should have all of this figured out and fixed. And your families are probably perfect, right? Because you know how to do it. That's not true. Anyway. Right. So you brought up my next part. Right? Self-compassion. This is huge. Right? So self-compassion also helps us as practitioners deal with burnout, deal with boundaries, and effective practice. So self-compassion has those three elements that kind of come in the middle to form you. Right? Self-kindness, mindfulness, and common humanity. Being kind to yourself. That is so hard. We are our own worst critics. I put this outfit together 2 days ago, had different sweaters lined up that matched the colors, tried it on, took it off, tried it on, took it off, right? Because I'm more critical of it than any of you are. And finally, I have teenage daughters, so I said, what should I wear? And they picked it up. Mindfulness, how many of you use that in your practice? We're going to do an activity at the end. in mindfulness. Because again, I think a lot of us teach it. We talk about how great it is, because it is, but we don't often engage in it ourselves. And then common humanity, right, is those shared experiences, those emotions, those need to connect to other human beings, acknowledging that we all have parts of us that don't go well, that do go well, right? The shared experiences we have are greater than the differences that we have. Even with our toughest, hardest clients, the shared experiences are probably greater than the differences. So, how do you engage in not self-care, self-compassion? What do you do to be more compassionate to yourself? There's some of them here I don't know. If you put ifs, would you mind explaining what that means?
I think that's internal family systems.
Okay.
That's not mine, but I'm assuming that's what it means.
Maybe like if not this, then. I don't know. That's a great idea. The biggest one in there, which means most people put it, was giving ourselves grace. I think that's super important when we're working with other people. So, now that we have a good understanding of our ethical principles and compassion, what do they have to do with each other? What do we do? How do we take this when we're treating our clients? So before I go into that, why do you think, why do ethics and compassion go together? What's in here is it's both and. Sometimes the compassionate answer isn't the ethical answer. Sometimes the ethical answer isn't the compassionate answer. And so we'll talk as we keep going about how we can put the two together and why, right? So it's 10:45, which means we still have about an hour left. Let's take a break. 2/3. That's a lot. How many of you in here work with youth? Have you seen this? Right? How do you see it? What are you seeing? What do you see?
I would say, so most of my life, I've been with the calls, but just as mostly college students that are confident that they have the level of appearance that's more.
You do good, so I look good.
Yeah.
Yeah.
Yeah, I work with mostly younger children, and it's how their parents shows up for them. So parents always working, their parents always putting time towards like school, things like that, whatever their next achievement is, rather than taking credit for that. And I can.
It's really hard. I always struggle to like, when the parent would bring a child in that was struggling, I was like, but if you did this, right, this would be so much better. So if we think about what does this mean for our long-term health as a community, some of us are aging. I would like compassionate people to take care of me when I am not able to. And if 2/3 of our current youth don't feel that that's important, that's really scary. So 1/3 of Americans do not consider passion for others to be among their core values. When I was doing community mental health, one of the activities we were given by the organization that I worked with was a values sort. It's this, I still have it. 15 years later, I still have it. There's like hundreds of cards in here, they're business card size. They have all of these values that you might have with the definitions on them. And you would sit with a family and you would sort these cards out into like most important, least important, not important to me at all. I remember doing this several times, and here's the compassion card. That was always put lower in the category. So I remember seeing it too. At the time, I didn't really think much of it because, you know, you're in the throes of doing the work and you're not really thinking about data points and all that. But now it makes sense. Okay? But you want to think about the people that you're working with. When I was doing that work, I was working with people who were involved with Department of Child Services, who I was probably seeing during the worst moments of their lives. Were they going to feel compassionate? No, absolutely not, right? How do you see that work when we're thinking about the adults in our community? How is that affecting our overall community mental health? It's scary to think about our youth not feeling compassionate as we age, but even our fellow colleagues and adults not feeling compassionate towards each other. So nearly half of all of Americans believe that healthcare and providers are not compassionate. That hurts. So that study was done mostly for doctors, nurses, and medical professionals, but I still think it pivots over, right? And I find that interesting because just like we have our ethical standards, right? Medical professionals have ethical standards, and one of theirs is compassion. But nearly half of us don't believe that our primary care and medical professionals are compassionate people. 87 of the people polled in that same study believed that kind treatment by healthcare providers was more important than other key factors. The key factors they outlined in that study: driving time, wait times, and cost. People are willing to pay more for someone who is kind. I don't think that's a surprise. The wait times was a surprise. Because if I'm dealing with a medical issue, I don't want to wait. 87% of people said they would rather wait for someone who is kind than unkind in getting care. Modern challenges. These are some of the ones I brainstormed in like 2 minutes. One of the roles that I had when I worked in community mental health was supervising social workers who were out and about in the field. These were most of the complaints that I got. How many of you deal with these?
Are you saying how many of us do?
Yeah.
And is there challenges to
Challenges to doing your job, right? It's hard to give effective, compassionate care when you yourself are worried about how many hours you have to have.
Mhm.
When I worked in community mental health, there were face-to-face hours, and then there were those other hours. And those other hours didn't really matter because you weren't really getting paid for them. And those other hours are what was my notes, my planning, my debriefing for myself. That stuff didn't matter. It only mattered that I was face-to-face with a client. And some of that was set by the company I worked for, but some of it was also set by who we were getting reimbursed by.
Yeah.
Because I remember going back and forth. At one time, you could have 15 minutes per client to do notes, and then they took it away, right? And so these are challenges. Limited resources. I remember buying my own office supplies because we didn't have the money for that. Non-traditional hours. Everybody wants to see you after school. There are only so many after school hours. And cancellations or no-shows. When I first started in social work, it was common to, what we were told to do was if somebody no-showed or didn't answer the phone, you would go out to their house unannounced and knock on the door and hope they answered.
What? Yeah, that's a real thing.
Yeah. I'm sure some of you have dealt with that.
All kinds of bad.
We did that information.
Oh,
Different.
yeah.
I mean,
We wouldn't flip flop into the area.
we contracted with Department of Child Services. They had to have those services that week.
Oh,
So you had to go find them. Leave notes on their door, right? We don't do that anymore. Really not safe. Right? What other challenges are you facing right now in what you're doing? Because it's different depending on your role.
well, seeing a trend here.
Insurance is a big deal.
Yeah.
I'm so glad I don't have to do that. I'm sorry that those did.
Thanks for the sympathy.
You're welcome. If I do have help, I help.
Where's the action?
Some of these are so big. How do we get other people to have the same knowledge we do? Or to care enough about it?
We have to share it.
So important. I was so excited because CEUs are so excited. A breath of fresh air. So along with this, these challenges, because these are the things that make people feel burnt out. It's not the work, usually. It's not your clients. I do think it's important to know we're just coming off of winter too, where all of us feel a little. But a significant amount of people in the training, both in the room and online, are feeling a significant amount of burnout. Is it because of your work, or is it because of all those extra things that you have to deal with?
I think both.
Probably. Remember, we're still in this why. Why is compassion important? In 2018, this is Laurel Ralston. She works at the Towson Cancer Institute. 18% of the adults that she worked with had reported some sort of mental, behavioral, or emotional health disorder. 18% doesn't sound like a lot, but it's actually a lot of people. Of those people that she talked to, 3% of people over 12, I think it's pretty telling, over 12, reported illicit drug addiction or misuse. This isn't trying something. This is active addiction. People over 12. According to the World Health Organization, there was a 25% increase in anxiety and depression during COVID, and a 50% increase in telehealth usage during COVID. I'm sure those of you that work in that world saw it. Wait lists skyrocketed. People needing, not wanting, needing telehealth services increased dramatically. And those of us that aren't well versed in that technology had to learn really fast. But not only did we have to learn really fast, we were also dealing with COVID and anxiety and depression and needing help ourselves. The increase in treatment that was sought and the increase in telehealth usage was pretty telling during how stressful that was. It's hard to think about it now that we're out of it, but when we're in it, we don't realize what that was like because we were just trying to make it through. And I think for me, it lasted so much longer than I ever would have thought it did. So if we think about historical and or present things that are happening in our communities, in our nation, in our world, do you think it's impacting the mental well-being of our community?
Yeah, absolutely.
Of course. Right? Mental health was the largest cause of disease burden in the United States in 2015. If you're not clear what disease burden refers to the impact of a disease on a population, which encompasses both its health and economic consequences. It includes the prevalence, severity, and mortality of the disease, as well as the associated disability and loss of productivity. When we talk as a community, as a group, as a nation about what is costing insurance the most money, or what is harming people the most, I never hear mental health. Sometimes I'll hear substance abuse, but I'll hear heart disease, car accidents, gun violence, things like that. But mental health was the biggest cause of disease burden for us. Right? We're still talking about the why. Why is this important? 1 in 5 people reported that they or a family member needed mental health services. But I think the most eye-opening for me was that 21% of those people went without care. They went without care because they couldn't afford it. Their insurance won't cover it. They're afraid to ask for help, or they don't even know where to go. Mental illness in 2013, $89 billion, which sounds like a ton of money, was only 5% of all medical spending. And I'm pretty sure if we spent some more money in there, we would spend less money elsewhere. One of my favorite things to talk about. ACE scores, right? How many of you have heard of ACEs? We've been using it for so long. Seems like so long. The original study was done between 1995 and 1997. Very large scale study with 17,000 participants, which is a ton of people when we think about research studies. ACEs was divided into 3 categories. So abuse, neglect, and household challenges. How many of you have ever taken the ACE study yourself, the questionnaire? Yeah. So you kind of know where you fall in that. They have been able to kind of pull out this data by all kinds of different groups and things like that. So you can really pull what your population of people you work with is. But then when we look at ACEs and long-term health, that's where big picture stuff starts to come in. Okay. We noticed suicide attempts go up the higher your ACE score is. Underlying chronic depression goes up the higher your ACE score is. Sexual behavior in teenagers goes up the higher their ACE score is. And these are just 3 out of the many that you can pull. We know that it has lasting impacts on people, right? Trauma in childhood has lasting impacts. But again, what does that have to do with compassion? What does it have to do with ethics? If you experience significant childhood trauma that you have never addressed, are you equipped to handle compassionately with other people? If you think back to that client that we talked about earlier, the one that doesn't ever seem to be happy, that can't relate to other people, I wonder what their ACE score would be. Pretty sure I could guess it's going to be on the higher end because we know that these have lasting effects. And I can't act compassionately if I'm not there. So, the follow-up though, it's not all doom and gloom. It's not all bad news. After the ACE study came out, they also came out with a resiliency questionnaire. So this is how we see people who have had significant trauma, who seemingly appear okay. Right? We all have trauma, some way, shape, or form in our lives. And we know trauma is a very individual thing. Everybody experiences it differently. We could all experience the same traumatic event, and it would all affect us differently. In the resiliency questionnaire, I highlighted, not very straightly, but I highlighted a few of the questions. If you look at those, what do you notice?
Community.
Extended support, community, somebody helping, right? And we know now that compassion is action. People are able to move beyond trauma if someone helps them in a compassionate way. So, I was reading that book on compassion. This is where all of these came from. Being compassionate in our work leads to better outcomes. I know you know this, right? You've seen it happen. But when we can put data behind it, then we can take that to people and say, this is why we need more funding. This is why we need proactive care, not reactive care. Right? In patients with depression, they found that patients improved significantly when they had a person who was compassionate in their treatment. Not a family member, not a friend, an actual clinician.
One of the things that I generally try and do is encourage people that I'm working with who are depressed to do something to give back. And that, I think, probably more than any single technique that I have ever tried to employ really seems to work. And I think what you're saying here, or what you were saying earlier about how compassion ties in with dopamine hits,
Yeah.
It's a really great way for people to feel better, not just chemically, but about themselves, for being needed, for being able to do something kind for someone.
Right, a purpose. When we have a purpose, it makes us get out of bed in the morning.
Mm-hmm.
Right. So what I took away from this too is that you don't have to have all the answers. I know I've been sitting there and I'm thinking, I don't know what to do. You just told me this whole huge thing. Where do we even start? Right? You don't have to have the perfect thing to say. You don't have to have all the latest training. You don't have to have all those technical things and certifications and all of that. Because what's more important is acting compassionately with our clients. So that's great. Like, I think we can see where it helps with depression. It helps with anxiety. Right? Every kind statement that a patient heard from a hospitalist, we're going to talk about what those people do in a few minutes, decreased anxiety by 4.2%. So if you said 3 kind things to a person, you could potentially decrease somebody's anxiety by over 12%. That's pretty significant. So anxiety and depression, those are the 2 biggies. I think we see a lot of those. There were 2 brothers that were doctors that started looking at compassion and post-traumatic stress disorder. They found, not surprisingly, that the earlier that treatment happens for someone who has PTSD, the more effective the treatment is. If you don't have to dig backwards years and years and years and years to try to fix something, it's easier to fix. I think that's true for most problems. So they noticed in a hospital, there were people that were called child life specialists. Does anybody know what those are? Yeah. I've never heard of this. Child life specialists are trained people who come in when children have experienced significant medical traumas, and they explain things to them. They tell them what is going to happen. They show them what is going to happen to them. And they explain how all of those people that are going to be coming in with pokey things and prodding them and scary stuff is going to help them. Now, again, like fate, there was just a WSBT article about 2 weeks ago on a child life specialist at Memorial Hospital. And that's actually her pictured in this picture.
Very cool.
So she is sitting there, and I'm sure it's just maybe her own child or something. But she has, in that little picture, a tiny CT scan that she's letting that child put a Barbie doll through, so that when that particular child has to go back for their own CT scan, they already know what's happening. So child life specialists were brought in and trained to decrease nightmares and emotional outbursts in children that have to have medical procedures done. Could you imagine if somebody did that for us as adults? How many times have you ever had a medical procedure and they just take you down and they make you do whatever they're doing and they don't explain it. It's terrifying. Right? And so I think it's amazing that we figured it out for kids. It's compassionate care. Now we need to do it for adults. So we could go on and on in that particular book. I mean, they talk about all different kinds of diagnoses. But I think you're well aware that compassionate care has a positive effect on outcome for people. And it probably could affect every diagnosis in the DSM that we see. So we know research indicates that compassionate care increases patient outcomes. So we're called upon in all of our ethical principles to act on the best interest of our clients, to do things that are in for them, right? So we have a commitment to help not just our clients, but the public. So compassionate care gives people that ability to feel more engaged, more empowered, and to have factors of resilience. So then isn't it right that treating our clients with compassion is ethical? So I want you to think back, way back to the beginning when we talked this morning about why you got into social work and mental health in the first place. And how burnout you feel today. When we're burnt out, are we effective? Do we provide the best care? Do we provide the best care to our clients when we're not acting compassionately with them? Do you ever remember a time in your career when you said to yourself, I cannot work with blank population? I did. And then I found myself working with those people. Because it doesn't matter who our clients are, compassionate care helps them be empowered to make the changes they need to make. Okay? So we're going to put, how many of you have a lens you work through? I work through a trauma lens. It's where I come from. It's what I've been most interested in. It's what I've learned most. I'm going to challenge you today to work through a compassionate lens. What would happen if we looked at all of our clients, our organizations, our employers, our systems, our colleagues, ourselves, compassionately? How would that change what you're doing? So, our ethical standards call on us to do a lot. There's a lot there when we read through all of those. These are the places I saw compassion most in those ethical principles. I think it probably encompasses all of them. It's not to say it doesn't fit elsewhere. That's just what I thought. You could think differently wherever you want to put it. When we're all out doing the work, we all use different lenses. I use trauma. Some people use family systems. Some people are using CBT to look at things. Some people are looking at things through organizations as systems. Some people are looking individually. We all have different lenses we're looking at things. So today we're going to talk about compassionate lens and what that means for working with our clients. There's 6 parts to using a compassionate lens. Empathy and understanding is the first part. So remember, at the very beginning, we talked about they're all connected: empathy, sympathy, compassion. Taking that time to remember, we are working with people, not hours, not cases, not numbers. We are working with people that we at times are seeing in their very worst moments. A non-judgmental stance. Oh, judging is so easy. We're hardwired to be negative and judgmental. And so taking on a non-judgmental stance can be difficult, but we have to look at a person and their situation. It takes practice to bring on that non-judgmental part of ourselves. In advocacy for social justice, it's tiring, it's hard work. Trying to keep everything that is happening in our country, in our world, in our communities, taking that on ourselves and then advocating for that change when other people are advocating for something completely different. And then a focus on well-being. Not just the well-being of our clients, also our own. We prioritize their well-being and the well-being of our community. Because sometimes what is good for me isn't good for all of you. And so when we look at things in a group as a whole, that changes how we might address something. Here's the part, active compassion. Skillfully means looking for new ways to engage with clients, keeping our trainings and skills important. We talked about you don't have to have all those right answers. You don't have to rush out and get 15 certifications by the end of the year and do 25 trainings. Take what you have, build on it, and use it compassionately. And then lastly, that self-compassion piece. Those three parts, mindfulness, self-kindness, and common humanity. Making sure we're always thinking about those things too for ourselves. Because again, when we're burnt out, we aren't effective. So I think here's everybody's favorite part. Now that we've talked about it, we know the why, we've seen the data, we get to go to the doing. So it wouldn't be an ethics training without scenarios to go through. So I have 3, and I'll throw them up on the screen too for you to see. And it works well because we have 3 rows. So you guys can do scenario 1 and 2 and 3. Right? You all have the same questions to go through. It's just a different kind of case study. So if you're not a social worker, forgive me, because I wrote these from a social work lens of things that I've either actually dealt with or could foresee coming. If you don't know where your ethical standards are, here they are. Hopefully those links will still work. I'm going to exit out of this and put those scenarios up for you really quick in an effort to save paper. We're going to come back and answer these questions. So our first group on this side, you can read, unless you want me to read it to you. Anybody want me to read it? And give me a thumbs up when you got it. Okay. The middle section there. Okay. Middle group, give me a thumbs up when you got it. I tried not to make that too easy. Sorry. Okay. So initially I have allotted 20 minutes. We don't have that much time. So take about 5 to 10 minutes to talk about this in your group. What you would do as the clinician in these scenarios, how you would handle what's going on. I hate to cut you off because this is always a nice part where you get to talk to each other. But we have about 5 minutes left. So we're so this leaves us about a minute or two for each group to kind of report back and how did you all even talk about that? How did you address it? And how did you look at these through a compassionate lens? They weren't easy. 2 out of the 3 of these I've dealt with. One of them is my own son. Okay, so group 1, what did you do? How did you look at this?
So through a compassionate lens, I think everybody's social work that's the first thing to provide that support, right? And so we look at it from several different lenses, from providing support to Lori to see what level of support from the parents. We also discussed the importance of gathering maybe resources, maybe seeking external resources if there's something internally that we can't navigate, like we didn't talk about it, but maybe like the ethics board that you were talking about to kind of help us solidify some answers in that. It was important for us to make sure that we're a safe in all environments. And have that advocacy for them because we don't know what situation he's dealing with at home. Because oftentimes the school is your safe place. Sometimes. And so now that we have the bullying as a factor, the place where they don't feel safe.
Right. And I think what made that one hard, if any of you are aware, the SB 140 that came down, limited mental health workers and social workers from providing referrals and resources to agencies that were providing gender affirming care.
What?
You could still provide mental health gender affirming care, but you could not refer to a doctor's office that would give gender affirming medical care.
Oh,
Now, the likelihood that somebody's gonna know that you did that and find you and whatever is pretty small. But that's where that came in,
wow.
right? That was a year or two ago, that happened
For children.
for children.
Gotcha.
It actually led to the shutdown of one of our biggest gender affirming healthcare providers here in Indiana. So. All right, our second scenario, what would you do? It's illegal to copy those documents. You have a kid who's nervous.
So we were talking about how, we provide that support for him, obviously he's scared and finding out, what those, what is he afraid of and trying to provide that support. Because he might be thinking that he's in trouble or whatever, but he's really not. So just finding that, just that, what's happening, why is he worried, what's he might not have to copy the document. There might be other reasons, might find another way to support him, just that lesson, that anxiety. Obviously, that's impacting so many other areas.
Right. Because we know it's a hard time anyway when kids go to college. And then you have this and a whole bunch of other stuff. So that was the one that was my son. We copied the documents. Made wallet-sized cards he can carry around. Because it lessened the anxiety enough that he was able to go back to class. So. All right, our third group. What do you do?
I think we kind of have varying opinions.
It's a hard one.
Disagree about it.
I think the situation requires a lot of, I think, assessing a little bit more about what's going on behind the scenes, as well as setting some boundaries with Ellen that, while it is, of course, totally okay to work with someone or expected to work with someone who is different than the provider, either politically or ideologically. Hateful speech about people, especially if in this scenario the provider is a person of color, and I'm assuming that the white nationalist propaganda is spouting racist things.
Not always.
Not always, though. I don't think of the provider, to be expected to take all that. So I think it'd be okay for the provider to set some boundaries of what is okay and what's definitely not okay. And if the provider does not want to continue working with Ellen, I think that I think the provider should discuss that with Ellen and try to facilitate setting her up with another provider. Not just dropping her cold turkey right then.
Sure. Right. And that happens, right? We do come across people that we just can't work with. And sometimes the compassionate thing is to give them to somebody they can work with. Okay. So if that's interesting to you, I would recommend, there's a book called The Klansman's Son, written by R. Derek Black. He was slated to become the next leader of the white nationalist movement. And he denounced his family, denounced the movement, wrote a book. The book is how he came out of living that life and what got him out of it. Guess what got him out of it?
A therapist.
No.
Oh.
No. A compassionate friend who sat and listened to him and challenged him and provided him resources. So, again, I think that person actually did go on to become a clinical psychologist, but they were in college when all this happened. So, but it was compassion. He mentions that specifically in the book. Compassion took him out of white nationalism. So,
I wanted to ask you, and by the way, you did a great job
Thank you.
presenting. I don't know what you're talking about when you say you're not good at this. You're very good at this. So thank you. This was super interesting. But I wanted to ask you and follow up about the book that you were reading that sort of prefaced all of this. That sounds very interesting.
The book is called Compassionomics.
Okay.
It was written by two co-authors, doctors. I don't remember their names off the top of my head. They wrote it because they saw that compassionate care was leading to better outcomes for their patients. And they wanted to put it like doctors do, right? Hard science people in black and white with statistics. It's a very easy book to read. Because I was like, oh, I don't know about you, but reading those technical papers is always really difficult. So this one is a very easy book to read. So if you're interested, I'm in a reading group on campus, and we actually get to attend a talk with one of the authors. And so you can always send a real follow-up about what he says if you want me to.
The one thing I would add is that, we're doing a summit in April on trauma-informed care and kind of where have we been able as a community to implement trauma-informed care and where we still work. And I could easily take the word compassion and translate, put trauma-informed care into there. And I think that sometimes we use the word trauma-informed care when we really need to use the word compassion and kindness, and that, that people need to understand that it's not some difficult thing. It really is about, I'm in front of you, I'm listening to you, and I care about you.
And
So,
compassion is easily digestible. Trauma-informed care is scary.
Yeah.
yeah. So, thank you.
Thank you.